Pneumonia is common in exam questions. You would normally know what pneumonia is, and it generally presents in many forms with coughs, productive sputum, hemoptysis, sometimes breathlessness. Patients with pneumonia would have fever with rigors and can have localized chest pain. Some findings would include tachypnea, tachycardia, low blood pressure, cyanosis. Confusion can be an important feature in elderly people, pleural rub, bronchial breathing, and crepitations. Common investigations done for patients with pneumonia include routine bloods, full blood count, blood cultures, infection markers, and acid-base gas. X-ray could be normal in very early pneumonia or could show infiltrates either as a homogeneous localized consolidation or bilateral fluffy shadows. X-ray could also have a sympneumonic effusion and sometimes changes like cavities and abscesses. You could consider taking a sputum sample for culture, and sometimes serology could be required for Mycoplasma, Legionella, or other atypical bacteria. If there is enough collection in the pleura as an effusion, then sample could be aspirated for culture. Now, a clinical score for prognosis is called CURB 65, commonly used in the UK. These stand for give a score for confusion, high urea more than 7 millimoles per liter, high respiratory rate more than 30 per minute, low blood pressure systolic less than 90 or diastolic less than 60, and age more than 65. If the CURB 65 score is 0 or 1, you can manage the patient at home with oral antibiotics. If the score is 2, admit to the hospital. If the score is 3 or more, consider intensive care unit. Risk factors for pneumonia include old people or very young children, immunocompromised individuals, people with chronic illnesses, mainly chronic respiratory illnesses like cystic fibrosis or COPD. Some individuals are prone for aspiration, for example, those who are bedridden or after stroke, patients with diabetes mellitus, patients who are ventilated, or air conditioning can be a risk factor for Legionella. Now, pneumonia is caused by typical bacteria like Pneumococcus, Haemophilus influenza, Staphylococcus aureus, or Pseudomonas, but sometimes with atypical bacteria like Mycoplasma, Chlamydia, or Legionella. Some viruses cause LRTI, influenza viruses, RSV in young children, or adenoviruses. Protozoal infections like Pneumocystis carinii are important in immunocompromised individuals. Rarely, a fungal infection with Aspergillus is also seen. Now, in hospital-acquired infections, they're generally pneumonia caused by gram-negative bacilli or Staphylococcus. Patients who aspirate and get a pneumonia can have infection with anaerobic bacteria or bacteroids. Now, managing a pneumonia requires appropriate antibiotics, either oral or intravenous, as per the local hospital policy. They need supportive care and monitoring. They may need oxygen, IV fluids, may need VTE prophylaxis or pain relief. They could require monitoring with frequent blood gases or continuous oxygen saturation monitoring. ITU may be needed if the CURB score is 4 or 5. Respiratory failure could be managed if PaO2 is low or PaCO2 is high. Patients may also have shock or reduced consciousness levels, and this needs to be managed. Some complications of pneumonia include pleural effusion, empyema, lung abscess, respiratory failure, pericarditis, septicemia, atrial fibrillation. Now, for exam purposes, a few features need to be remembered. Legionella lives in water tanks and in air conditioners. Patients have dry cough, breathlessness, and confusion. X-ray will show bilateral consolidation, and antigen could be tested in urine. Pseudomonas infection of lungs is common in cystic fibrosis or bronchiectasis, or in intensive care unit in ventilated patients. Suspect staphylococcus infection in patients who are IV drug users, but also in elderly people and in cystic fibrosis. X-ray will typically show bilateral cavitation. Mycoplasma infection leads to dry cough, bilateral infiltrates on X-rays, sometimes hemolytic anemia, which is autoimmune, or other disorders like erythema multiforme or Stevens-Johnson syndrome. Pneumocystis carinii, also now known as Girovecchi, also has dry cough, breathlessness, and desaturation. Common in immunocompromised or HIV. X-ray could be normal or have bilateral perihilar shadows. These patients require septrin or pentamidine.